All right, folks, we're going to go move on to gastroenterology chapter 5 here at MedQuest with inflammatory bowel disease. Now, our first question with inflammatory bowel disease is a long vignette. Keep in mind, a lot of the IBD cases are going to be very intricate and very, very long and arduous. But you have to be getting good at this point at picking out the clues and concepts that are important. Let's go through this one. A 44-year-old woman presents with diarrhea, weight loss, fatigue, and right lower quadrant pain over 2 weeks. She's had 3 to 8 watery bowel movements per day with mucus, no melena, and no hematochezia. On physical exam, you find a low-grade fever, injected sclera, multiple aphthous ulcers in her mouth, decreased bowel sounds, and tenderness in the right lower quadrant. There are multiple coin-sized erythematous lesions on her shins, and a rectal examination reveals small perirectal fistula. Oh boy. And the point here they want to ask is which finding is exclusively associated with Crohn's disease? Which of the following is only seen in Crohn's disease? Is it a low-grade fever? Nope, that's seen in both. Is it right lower quadrant pain? Nope, that's seen in both. Is it erythema nodosum, those coin-shaped erythematous lesions? Nope, that's seen in both. Episcleritis, a lot of us used to think that was ulcerative colitis alone, but actually it's in both. And the perirectal fistula is all that's left, and that's true. A fistula is specific to Crohn's disease. Remember, GIFs, granulomas, intestinal involvement, fistulas, transmural, and good old S. What does S stand for in Crohn's disease? Well, it's going to be small bowel. S for small bowel, meaning the terminal ileum. Now, what is the best single test to determine the presence of Crohn's disease? The single best test? Well, that is going to be a small bowel series with air contrast, known as enteroclysis. Which dermatologic or ocular manifestation of Crohn's disease does not correlate with activity of the disease? Well, that's kind of interesting. That's pyoderma gangrenosum. Now, for those of you who have never seen pyoderma gangrenosum, it looks almost like a large draining abscess on the skin. But what's crazy about this is that whenever you treat Crohn's disease or you even treat ulcerative colitis, the pyoderma gangrenosum doesn't get better. Erythema nodosum, episcleritis, and maculopapulosis actually, as you treat the colonic issues, those get better. What medication should be initiated in the patient who has mild to moderate inflammatory bowel disease? Now, of all of these choices, mesalamine is the best choice. Now, what are they going to ask you about sulfasalazine? Now, in mild moderate inflammatory bowel disease, mesalamine is always correct. Prednisone is not really correct. That's really going to be to put somebody into remission. They're not talking about that here. They're talking about initiating therapy in mild to moderate disease. Ciprofloxacin, along with metronidazole, is used in perianal disease, in inflammatory bowel disease. And the question they're going to ask you about sulfasalazine is that which of these medications is the patient with IBD already on that's going to cause reversible infertility? And that's going to be sulfasalazine. If the patient does well on mesalamine and then relapses, what should you add on next? Then you go up to prednisone. Remember, now you got to try to put the patient into remission because they're no longer mild to moderate. They've relapsed. That means they're going to be upgraded to moderate to possibly even severe. On tapering the prednisone, she has relapses. She has relapses while on prednisone. Now you've got a problem. What medication should be initiated in this patient to have an avoidance of steroids? Meaning, what should you do to have steroid tapering, or which medication is going to cause steroid sparing? Meaning, how do you get this patient off steroids? And the answer there is 6-mercaptopurine or azathioprine. These are immunologics that help a patient bridge and get off of steroids. Now, you have a patient who has ulcerative colitis, Crohn's disease, and they have an elevated alkaline phosphatase. What do you suspect? Do you suspect bone disease, a common bile duct stone, biliary sludge, primary biliary cirrhosis, or sclerosing cholangitis? The answer here is sclerosing cholangitis. That means this patient has primary sclerosing cholangitis, an extraintestinal manifestation of good old ulcerative colitis and Crohn's disease. A lot of us used to think that ulcerative colitis was all that was associated with episcleritis and having primary sclerosing cholangitis, but the fact is that they're almost equal in Crohn's and ulcerative colitis. Elevated alkaline phosphatase is seen in bone disease. But you really should not be thinking of bone disease in a patient who has inflammatory bowel disease. Your first thought should be the alkaline phosphatase should be coming from the epithelium of the biliary tree. When you rub that epithelium and you rip it apart with sclerosing fibrosis or stones, your alk phos goes up. Primary biliary cirrhosis is typically going to be a young, middle-aged female with itching and xanthelasmas, which are cholesterol deposits around the eyes and elbows. That's going to be treated with what? And how do you diagnose it? Well, it's pretty straightforward. Primary biliary cirrhosis is diagnosed by checking an anti-mitochondrial antibody and getting a liver biopsy, and you treat it with ursodeoxycholic acid. Which extraintestinal manifestation of ulcerative colitis specifically is not affected by the early colectomy? That means of all of these, if I go ahead and say, you know what, doc, remove my colon altogether, I don't want to deal with it, you have to tell them, well, listen, your liver is still at risk. Because colon cancer is taken care of, the joints get better, even the eyes get better, but the liver will still have disease. A person with Crohn's disease involving the ileum is at risk for developing which of the following? Now, Crohn's disease is like in our last chapter, it's a malabsorptive phenomenon because it affects your villi. What that means is they're at risk for developing all of the above. They can develop calcium oxalate kidney stones from malabsorption, cholesterol gallstones from malabsorption, B12 deficiency from blunting of the actual villi, and bile salt diarrhea because you don't have that enterohepatic circulation to retake those bile salts out, and so they cause diarrhea. After being treated with mesalamine and azathioprine, a fistula to the perianal region develops. What medication should be added to assist in healing the fistula? There's only one medication that will close the fistula, and the others for perianal disease, and that is infliximab with ciprofloxacin and metronidazole. Now remember, before starting infliximab, you have to check a PPD in the patient. Why? Because infliximab is a TNF inhibitor. When it's a TNF inhibitor, the only thing that keeps that granuloma in the top of your lungs with all that tuberculosis inside of it is TNF. And so what ends up happening is when you inhibit TNF, that granuloma is going to go boom! And all that good old tuberculosis is going to be like, hey, I'm here to party, let's get it on. So you're going to have a problem there. Now, big question, which of the following is associated and statements are true about colorectal cancer and Crohn's disease? It usually occurs in women. The frequency of carcinoma is similar to those patients with extensive, long-standing, unresective Crohn's colitis to those patients with extensive, long-standing ulcerative colitis. The right colon is involved in over 70% of cases. The mean age of patients with colorectal cancer is 35. Or the occurrence of carcinoma is unrelated to the duration of Crohn's disease. The answer here is B. The frequency of carcinoma is similar in unresected Crohn's to long-standing ulcerative colitis. Your next question is, which of the following does not occur after extensive ileal resection for Crohn's disease? And the answer there is iron deficiency anemia. Why? Because you absorb iron in your duodenum, and this is an ileal resection. Nephrolithiasis will occur because you're going to develop calcium oxalate stones from small bowel short gut syndrome and malabsorption. Same thing will occur with cholelithiasis, B12 deficiency, and bile salt diarrhea. It's all from malabsorption. But iron is absorbed in the duodenum, therefore you will not develop iron deficiency anemia. Which medication is effective for inducing remission, but is not effective in maintaining remission? And that answer is steroids. Remember, steroids will push you into the remission truck, but then you got to use something to first get the person off of steroids and then keep them in remission. Those answers are typically going to be 6-MP, 6-mercaptopurine, or azathioprine. Which of the following is the most likely cause of a relapse of ulcerative colitis? A relapse of ulcerative colitis is always NSAIDs. Ladies and gentlemen, NSAIDs, for whatever reason, through their molecular inhibition of the COX enzymes, will cause a relapse of ulcerative colitis. You have to counsel your patients not to take their Aleve. Stick with Tylenol. Spicy food, raw vegetables, and smoking are always wrong. Ladies and gentlemen, spicy food does nothing except taste good. It doesn't cause ulcers, and it doesn't cause a relapse of ulcerative colitis. I'm Indian, take my word for it. There's a billion of us, and none of us have these issues going on. Now, raw vegetables are only good for you. And here's the weird one. Smoking has actually been found to be protective in ulcerative colitis. But that does not mean you tell your patients to smoke. There is no such thing as a prescription for my bowels feel so much better. There's no such thing. Smoking is always bad. Now, reducing the risk of colon cancer in inflammatory bowel disease is related to which of the following? And that's pretty straightforward. And that's going to be surveillance colonoscopy is actually shown to reduce the mortality in IBD. Giving vitamins, long-term steroids, and an annual barium enema is not going to do anything except fill you with barium. Ladies and gentlemen, those are the most high-yield questions you're going to see on your ABIM, your Step 3, and your Step 2 on inflammatory bowel disease. I'll see you in the next chapter.